So we are here back. Raised ICP. Okay. Raised intracranial pressure. You all know. You all know about intracranial pressure, right? Last time we discussed about cerebrospinal fluid. Most of you were in class, no doubt. So, raised intracranial pressure, like how we have to discuss, like we'll go one by one, don't worry. And I would draw one diagram, then we'll discuss in brief about like cerebrospinal fluid as well. And then after that, we'll continue with our class because this will go for, like little longer. And we'll see the causes, we will see the investigations, we'll see even the treatment part. Okay, cool. So the skull is basically what? Skull is basically a very tight structure, very rigid structure. Okay, so like completely brain, fluid like cerebrospinal fluid and even blood, these all are, you know it's like these are incompressible, and any one constituent, if it is increasing, or you can say if it is expanding mass within the skull, it will result in intracranial pressure. Okay, this is very famous. If they ask you, so you remember that. This is called Monroe. Yes, correct. Kelly doctrine. So, what is the doctrine? What is the principle, dear student? Principle is skull is a rigid structure. So, its contents like brain, cerebrospinal fluid, blood, these all are incompressible. So, increase in any constituent, any one constituent will result in increased ICP, that is intracranial pressure. Remember what you wanted me to write? Acha, constituents. Yes, yes. You can always remember. I'll write it down. Don't worry. It is blood. It is brain, and it is CSF. Either blood, brain, CSF. All these are incompressible. So anything if increases, not just one, anything if it increases, it will cause what? To increase the intracranial pressure. Cool. Now give me few minutes time. Then I will draw the diagram and I'll make you to understand. It will be easy to understand. You hope you all remember the anatomy of cerebrospinal fluid that day we were talking about, like how it is getting produced. Anyway, we'll come back again on that in a very simple manner, a very brief manner, so that it will go. Then we'll see even the edema in the brain as well. Okay. So let me go to the. Everyone is able to see that? Okay, okay. Give me 2 minutes time. Few minutes time, in fact. Take some time to draw it. Yeah, yeah, definitely. You must draw with me. If you have to become a good professional, you should always follow the class with the notes and pen. Not just my class, any class. It was just small, so you don't delete. I'll delete because of my page wasn't permitting it. Okay. So this is basically, skull I'm able to show you. Okay. And this part I have kept it open because I just wanted to let you know that this is part where we will be showing the, like, it descend down in the spinal cord. Okay. So I'll change my color. I don't know. You're able to see, yes. So, so basically, not able to see. Okay, no problem. I will use another color. I'll use the red color. Lumbar CSF. Okay, descending down. I'm talking about the. It is, like, descended down in the spinal cord. Let me draw first. CSF 100 to 150 ml. No, this is for making you understand. This is nothing that you should just remember, like how compensatory mechanism work. Yes. So there is a blood 100 to 150 ml. Okay. I'll indicate it. Don't worry. I'll let you know. I'll let you know. Give me some time. ECF. Every one of you understand? ECF, extracellular fluid, 100 to 150 ml. Tumor or hematoma or abscess. Okay. it is a normal brain tissue. So either tissue which is 300 to 400 ml, and then fluid will be, what is the part of brain is water, how much percentage? 900 to 1200 ml. 80%? No, no. Think about it. Until it is intracellular, which is common. Intracellular. Okay. CSF absorption. I'll make you understand. Don't worry. CSF absorption. Where does CSF get absorbed? Anybody? Arachnoid villi. Okay. Where is CSF getting produced? No, no. It is produced by ependymal. That I'm not saying ependymal cells. I'm talking about, yes, choroid plexus production. Now come. I kept it in red just to make you understand, nothing else. Okay, well, now think one by one. Okay, so CSF absorption, actinoid villi, CSF production, choroid plexus. Okay, so like this, blood 100 to 150 ml. Okay, and then CSF production. So I can tell that it will go like choroid plexus and it will back to the CSF production, right? So like this, and extracellular fluid also will have to have interaction with CSF, extracellular fluid. You understand my point? And then ECF has connection even with the blood, direct connection, right? So now down is lumbar CSF, upper. Let us take, yeah, brain. To I made you understand like tissue, fluid, intracellular, and I asked you also the question. Yes. So what are the causes of, once you understand this, then you will be able to catch my point what I'm saying you. Causes of ICP, intracranial pressure. First is any tumor, hematoma, abscess. What it is doing? In fact, what it is doing? Anyone? Yes, correct. It is like taking space over there. So we can take it like a, we can say it is a expanding mass. Why I'm telling you expanding? Because it could increase in size. Right. Okay. Now come to the second reason. Yes, I'm talking about this reason. Number one, causes of ICP. Number two, either increase in the fluid part of the brain, either ECF or intracellular fluid. If these two are getting increased, then ICP can get increased, means intracranial pressure can get increased. So what is the reason? It increase in, yes, we will keep it very simple, brain water content, right? Basically this. Or suppose the blood is increasing because of uh, some obstruction, okay, usually venous flow obstruction or vasodilation. If vasodilation is increasing the cerebral blood volume, so this is also the reason of Remember the doctrine, right? Increase in cerebral blood volume. Okay, so what it will cause? That's what I'm saying. You, it could be caused because of vasodilation. It could be cause of vasodilation. I will not write it here. You should understand that. It could be cause of vasodilation or it could be venous outflow obstruction. But whatever be the reason, it is increase in the cerebral blood flow. Sorry, cerebral blood volume. Okay, flow and volume. I'm not getting confused. So it's a cerebral blood volume. So anything increase, this will cause. Okay. Now, if apart from these all reason, one more reason I'm taking it into account is if it is an increase in CSF, more volume, increase in CSF, uh, it could be either like it is not getting absorbed properly, you know. So I can say that less absorption. No, I would say that more secretion is rare. So more secretion, if you are telling me to tell, I would say that more secretion is quite rare. It is mostly the less absorption of CSF, which increases in the volume, and then it causes the ICP raised. Clear? Huh, yes. So, like here we will take it, here we will pen down one like compensatory mechanism of intracranial mass lesion. Suppose this intracranial mass lesion is increasing. Okay, so there is a tumor increasing in the brain, or hematoma is increasing, or in the case of abscess, what will be the compensatory mechanism? Now you can understand. Compensatory mechanism, what it will be? It could be either immediate or it could be delayed. It's not necessary that immediately CC as intracranial pressure will increase. It could be immediate. In which case it could be immediate. Either CSF volume is down and CSF is coming down into the lumbar area. Okay, or it could be low cerebral blood volume. Okay, it is how it, this is how it will get compensate, right, immediately. But in case of long this one, what it can be? Low ECF, extracellular fluid. Okay, so this is just a compensatory mechanism for this, particularly this one. So for, I'll write it down only here, intracranial mass lesion. Any question you have on this? So it's basic that, you know, like you should understand the brain structure is too tight. So anything increase inside, either it's a brain water or cerebral blood volume or CSF itself increasing, or any kind of extra mass coming, like tumor could be the extra mass, right? It could be even the hematoma, it could be even the abscess. It will cause the increase in the intracranial pressure. Understood? No, I just made this diagram to make you understand like how it works. That's all. I could have given you these reasons, that's all, but just to make you understand. No, thank you me only after when you study properly. Yes. Okay. Now next, CSF in brief. Let me see how many of you remember that. Okay. Have you revised it? Yes. So tell me. Okay. 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 No problem. I will only tell. Don't worry. I'll not ask question today. Okay. So 500 ml per day. This is the normal, right? From where it get originate from? Choroid plexus. Okay. So how it traverses? Through the ventricular system, correct? So through the ventricular system, and it will enter into the subarachnoid space via the fourth ventricular foramina of Magendie and Leska. Remember all the anatomy? Yes. So keeping aside anatomy, let us see normal condition and abnormal condition. Okay. Normal conditions, if we see how it work, it flows very freely through the subarachnoid space. Well, and where it is getting absorbed? It is getting absorbed. Just now we saw no arachnoid, like arachnoid villi, right? It get absorbed here and produced by that. Okay. Normal conditions, it will work like that. But if there is a obstruction to free flow of CSF, what it will cause? Wonderful. Hydrocephalus. But don't you think hydrocephalus will have now intracranial pressure more along with hydrocephalus, right? So, plus raised in ICP. Cool. Now, if this was one condition, okay, it was reason like related to flow. Now, if we see the second condition, here I'm writing ulta so that you can be here. Yeah. So expanding in any kind of intracranial mass, just now we saw in the last page, intracranial mass, if it is increasing, that also will cause CSF expulsion to the, just a minute, I'll go back to that page. Huh. Look at here. What I was saying, you suppose CSF is getting more produced over, like obstruct over there because of CSF and sorry, tumor, hematoma, or abscess, any kind of intracranial masses when it is increasing. So what is happening? It is actually causing normal CSF expulsion, right? Suppose this space has been taken over by the tumor cells, so it will be pushing the CSF. But why? Like where the CSF will go? You tell me. To the most is lumbar zone. It will go. Yes, lumbar thecal part. It will go right. So further expansion. Suppose further it is getting expanded. Then what will happen? You only tell. Brain has two parts, right? Right and left hemisphere. Everyone know. So one side, suppose right hemisphere has intracranial mass. So where it will shift all the CSF to? Yes, 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 yes. Please answer. I'm waiting. So further expansion, it will cause the brain shift also, right? Right to left. I don't want to right to left. It can cause, right? Suppose right side it is more, so it will causing the left, like subsequent shifting of the brain will happen to the left. So it's not that only in the lumbar area it will come, it can actually again cause, pressure over the arachnoid villi also. And if that is the situation, intracranial pressure will be much more, much more. Okay, intracranial pressure is increasing. And then what I'm saying, you suppose in third scenario, more and more expansion has happened. Intracranial mass is increasing. This will cause expulsion of CSF, right? To where what I was saying is lumbar theca, right? It will go down. But suppose even though more is there, so what will happen? Brain shift. So CSF will go where? It will be also to arachnoid villi, where it was supposed to be absorbed. Yes, supposed to be absorbed. So what do you think it will cause? It will cause the intracranial pressure abruptly high, acute rise, right? So I just told you normal conditions, CSF flow in arachnoid space. It is a normal condition, but where the abnormality start is obstruction to the flow. This is 1 degree, like suppose hydrocephalus happens, and after that it will increase the ICP, but further it will be causing expulsion of CSF toward lumbar theca. Even further it will cause the brain shift as well as the arachnoid villi. It will pressurize the arachnoid villi, right? And it will cause the increase in intracranial pressure, which is acute rise. So this is how it causes more and more severity. So severity level, you just check it through whatever I spoke just now. Okay, any question you have? No, you understood. Okay, cool. Now tell me, what is cerebral edema now? Huh, that is my question. That is my question. Yeah, what is cerebral edema? Wonderful. Refine your definition. Okay, always be clear with your definition. How much you are clear with the definitions, that is, that shows that how good are you in, you know, uh, concept. So it is basically an excess of brain water. True. So how it can be developed? It may develop around the intracranial mass, intrinsic lesion, brain tissue. It could be tumor, it could be abscess, है ना? Or it could be even the any kind of space occupying lesion, or even the intracranial, like what we say, ischemic brain damage. Have you heard of brain death? Ischemic brain damage, have you heard of? Sorry, brain death ko chodo. Ischemic brain damage, have you heard of? I don't want to make you scared, but have you heard of the cases where the person is running over treadmill and then all of a sudden collapsed, and later they say it's like a hypoxic brain injury? No. Okay. Yeah. So, like, if I talk about forms of cerebral edema, no, my voice is correct. I think you should check your gadget. You can increase the sound of your gadget. My voice is correct, I believe. There's no complaint from anyone. Yeah. So basically, three types. One is vasogenic. What is vasogenic? Okay, let me list out first three types. But what is vasogenic, by the way? You think it. Cytotoxic. And third is interstitial. Tell me, what is vasogenic? Here, what happened? Excess brain water, okay, it passes through the already damaged capillary walls, okay, to the extracellular fluid space. Okay, so what happened basically? ECF gradually go to the normal brain tissue. So basically toward the CSF, ventricular CSF, and this may add clearance like adjacent to tumor. Okay, so what happened here in vasogenic basically? What did I say? Vasogenic basically what happened? Excess fluid, what we say basically rich in protein, okay, rich in protein, passes through damaged vessel wall. Okay, damaged vessel wall. So ECF gradually, ECF goes toward towards CSF. Okay, in case of tumor, it could happen. Example, tumor. It may add even the clearance. Okay, cytotoxic. As the name says, what happened in this case? Huh? No, again, what you are thinking is not like that easy. So what happened in this case? Anybody? Fluid accumulates within the cell, within the cells. Clear? It accumulates within the cells. So it could be, it is basically what? Intracellular. So understood the difference now? Intracellular. It could be neuron cell or it could be glial cell. Okay, glial cells are supporting cells of CNS, right? In our basic anatomy lecture, we have seen all these things. Okay, what about interstitial? Here, CSF is CSF is in expulsion. It is forced through the ECF space. Here, what happens? CSF is forced into. You understood the point? CSF is forced into the ECF space. Remember that diagram? Okay. So basically, all this happening in the, like, if you ask me that way, yes, it happens mostly in the white matter. White matter. Here, definitely in the white matter. So preventricular white matter, we say that. Sorry. I'm really sorry. It's a periventricular white matter. This is how it happens. So these three types you remember. Anybody can tell me why cytotoxic, like how it happens? Because of ions like sodium ion and calcium ion increases. I hope you would have studied this similar phenomena earlier. Sodium and calcium ions increases in intracellular fluid, and this causes the swelling of cell. Yes, now you remember cytotoxic edema. So swelling of cells, cytotoxic edema basically. So capillary damage, obviously it will happen. Okay, so basically like after capillary damage, it will cause what? Capillary means the vessel damage. Now once the capillary is damaged, again it can go for vasogenic. Why? Vasogenic is all because of flow of protein rich excess fluid which passes through the damaged venous vessel wall. Okay, and that's where the ECF goes toward the CSF, especially in the tumor. It could be adjacent to tumor. Adjacent to tumor. Okay, it can happen. Understood my point? Brain water. Yes. Next page we'll see cerebral blood flow and cerebral blood volume. Cerebral blood flow. Okay, and cerebral blood volume. So how do you define flow in physics basically? So flow is, if you see mathematically, flow is equal to pressure divided by resistance. Have you ever feel that like a smaller, narrower space where the wind is more, even though you don't feel wind outside much, if you keep your hand near the closed door where the small narrow space is there, you'll find that wind is flowing. Why? Flow is equal to pressure divided by resistance. Cool. Now, inside the skull, as I told you, skull is a rigid structure. So here, cerebral, here we will talk about the cerebral blood flow, right? This flow we are talking about. So CBF basically in short form. And then what it will be? It will be also pressure divided by resistance, right? So what is the pressure? We say that cerebral perfusion pressure. These all concepts are to make you strong in the subject. एग्जाम में पूछता है नहीं पूछता है वो भूल जाइए. First try to make yourself strong. What is cerebral perfusion pressure? Anybody has any idea? No. Okay. Systemic. Everybody's, half of you said no at a time only. Achha, you asked question also. What is cerebral perfusion? It is nothing. It's just your normal systemic BP, systemic blood pressure minus intracranial pressure. Okay. You know very well that brain has autonomic regulation of blood, right? Yes. So, and divided by what? What is causing resistance? Cerebral, basically cerebral vesicular resistance. So this is how you calculate the cerebral blood flow, right? So in normal condition, what will happen? It will be related to the how much are you using the brain? I mean, how much the brain is using the energy, right? So that to maintain normal, to maintain, I would say that healthy metabolic uh, basically metabolic demands to maintain metabolic demands, basically the normal metabolic demands. Okay, so this complete mechanism will work on the arteries of the brain. I mean to say, like suppose arteries. I mean, when I say arteries, means not just artery. It's artery, and then it divided into the arterioles. Then it goes for the finer capillaries, right? This is how the thing is done. First is main artery, then arterioles, and then capillaries, right? So okay, so this is how it works. So to maintain normal metabolic demands, it will depend upon many regulatory mechanism. So you have a cerebral blood flow, autonomic regulation. Okay, so it depends completely on the arterioles, which maintain the normal cerebral blood flow just to maintain the metabolic demands. Cool. So when we talk about autoregulation, okay, okay, coming back to the autoregulation, I would like to just 1 minute. I'll change this so that you don't get confused. No, no, I'll completely make you understand about the situation it goes, like how it is getting maintained. Because once you understand this, you revise this, you'll be very, it will be very easy for you. Cerebral blood flow. Here we will talk about which all process, which all sorry, which all factors which actually decide, which are deciding factors for like cerebral vasculature. So factors affecting cerebral vasculature. So one is, as usual, chemoregulation, another is autoregulation. Huh, we will see about it. But first, you should understand what is chemoregulation. We will come into the vasoconstriction and vasodilatation. Don't worry about it. But one is a chemoregulation and another is a autoregulation. Okay. So chemoregulation is basically what? Change in extracellular pH value. Okay, so basically why it happens, or why it can happen, it is because of the metabolic byproducts which directly affect the vascular caliber. Okay, or any change of partial pressure of carbon dioxide and partial pressure of oxygen as well. But partial pressure of oxygen comes only in picture when, you know, like it's less than 50 mm of mercury, like that only it will be have a significant effect, otherwise no. Autoregulation, autoregulation What is autoregulation? If you define it, it is a change in pressure that results in the compensatory change in the vessel caliber. Okay, so any change in cerebral perfusion pressure results in compensatory change in vessel caliber. Okay, now we will talk about a little bit about the vasoconstriction and vasodilatation. So suppose I will take picture of vasodilatation first. Okay, did you understand this point? Then I will go little down and explain you. Vasodilatation. Vasodilatation. Cerebral vasodilatation I'm talking about. So I should write it. Cerebral vasodilatation. Cool. Now, you tell me, if it is a chemoregulation, what kind of chemoregulation will come into the picture? That's what I'm asking you. What kind of chemoregulation? Because if you understand this concept, many things you will be able to solve in neuro. So I'm telling you, what can cause the vasodilatation if it is a chemoregulation factor? Because autoregulation will definitely only require is what is CPP, cerebral perfusion pressure. So don't worry about it. We'll go in that later. First, tell me what kind of chemoregulation you can expect in case of vasodilatation, which can cause, how it will get regulate. So as we discussed earlier, partial pressure of oxygen higher and dilatation के केस में O2 less, very less in fact, and extra cellular pH should be low. That means it's an acidic environment, and more metabolic products. I would write rather byproducts. So these all chemoregulation will cause vasodilatation. And if it is an autoregulation, increase or decrease? Autoregulation, in case of autoregulation, how, like, which will cause autoregulation basically? Through CPP, but increase or decrease? Wonderful. Happy for you. CPP, decrease. That's how it's a vasodilatation. This is a case of autoregulation. You understood my point? This is how you should understand the science systematically. Okay. Now let us talk about the vasoconstriction. Cerebral vasoconstriction. No, a lot of syllabus has to be completed, but I'm going slow. One by one, we will be able to finish everything. Don't worry about it. So, which can cause vasoconstriction? If it is a chemoregulation, you have to come back to the partial pressure of oxygen. ठीक उल्टा. So, what will happen here? PCO2 decrease, PO2 increase. Yes, metabolic byproducts. It will have low. Yes. So this is how it will cause the chemoregulation. And increase in CPP. It is well known fact. CPP increasing means the pressure is increasing, which will cause the vasoconstriction. So this is what is autoregulation, right? Okay. So you understood the vasoconstriction, vasodilatation, basically. Yes. Now let us talk about a little bit about the autoregulation. So we will talk about the autoregulation. So what is autoregulation? How do we define it now? How do we define? Autoregulation is a compensatory mechanism which permits fluctuation in perfusion pressure, cerebral perfusion pressure within limits without significantly altering the cerebral blood flow. Okay, so there is no significant blood flow problem. Okay, so autoregulation is basically what? A compensatory mechanism, and it is the key of brain. A compensatory mechanism which permits fluctuation in cerebral perfusion pressure without altering cerebral blood flow significantly. Okay, so I would say that I'll make a small graph to make you further understand. Okay, the x-axis we will have a pressure, cerebral perfusion pressure. Okay, which is basically what? Systemic BP, SBP minus intracranial pressure. Okay, good. So now, and y-axis will take is a cerebral blood flow. I hope you are able to follow up this like a small. Uh, I'm 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 using all short forms. याद रहेगा ना? Okay, you want me to write? Okay. So I have taken what? Cerebral perfusion pressure on the x-axis and cerebral blood flow on the y-axis. Just 1 minute. Okay. In this, what I wanted to change, wanted to show you. Suppose this is the graph. Okay, changes are there. You can see the changes, right? It's not a straight line. So blood flow is maintained. Cerebral blood flow is CBF is maintained. Even there are changes in the CPP. Okay, so this is what I was saying you. Now suppose cerebral perfusion pressure, if it drops, okay, so it will cause what? Vasodilatation प्रेशर कम होगा तो वासोडाइलेटेशन ही होगा ना. हाँ. So it will maintain what? It will maintain the flow. Flow, I mean to say cerebral blood flow. Suppose CPP, cerebral perfusion pressure, is increasing. It will cause what? Yes, vasoconstriction. More pressure means vasoconstriction. Okay, so it will what? It will obstruct or limit flow, right? Obstruct is not a good word here. I would like the, it will reduce the flow. But it will, this is how it is, maintain the CBF, cerebral blood flow. This mechanism is understood now. But neurogenic influences normally, it doesn't have like it has a very little effect on vessels. Okay, so autoregulation acts, why? Because it can change the pressure, cerebral perfusion pressure. Now let us think about till what limit autoregulation works. Autoregulation has a limit, right? So I will read it better. Fail of auto regulation, so that you can remember. I will give you limit. Fail of auto regulation, when it gets failed, when CPP falls below 60 mm of mercury or rises above 160 millimeter of mercury. ठीक है. So what happened here? In these cases, extremes, cerebral blood flow will be directly proportional to the cerebral perfusion pressure. So more the pressure, more the flow. Sorry. I did not write it proportional, but I'll write it. It is related to cerebral perfusion pressure at these extremes. Okay, it is just to make you understand. But in case of damaged brain, either it could be head injury or any kind of hemorrhage, maybe subarachnoid hemorrhage or anything. So usually auto-regulation, I'm not talking about fail, I'm talking about it is impaired. So in that case, what happened? Cerebral perfusion pressure, if it is less, it will cause cerebral blood flow also less. And it can cause what? It can cause ischemia. Okay. In case of hemorrhage, right? Any kind of subarachnoid hemorrhage or head injury, anything. So just 1 minute, I'll make it more clear. Suppose there is a case of hemorrhage, subarachnoid or head injury or anything. So in that case, what is happening? As I told you, it can drop the autoregulation. It will not completely fail, but the mechanism will go down. So any kind of cerebral perfusion pressure which is low will cause cerebral blood flow low, that will cause blood will not reach to the place, so it can cause ischemia. Okay, but in case of high cerebral perfusion pressure, what will happen? It may increase the flow, and it could happen like blood brain barrier, which it can get breakdown, and it can cause the cerebral edema. Okay, or hypertensive encephalopathy, that's also one of the condition it can cause. So once you understand the basic, you'll be able to understand the mechanism easily. Any question you have on this? Okay, there are two questions are here. I'll just see. Oh, first auto regulation. Yeah, just now we saw no auto regulation. So your question is answered. Okay, second question is what? Okay, that will come on that. Don't worry about it. We'll come on that. We'll come on that. Don't worry. So once again, we'll see ICP. So what is the pressure of intracranial pressure? Like what is that? Like not what is that? I mean, what is the pressure value? It is 0 to 135 millimeter, or if you millimeter of CSF, or you can like in terms of mercury, like 0 to 10 of Hg mercury under the normal conditions. But if you measure relative to foramen of Monro, okay. So I'll just make a graph here. It will be easy for you to understand again. Okay, so this time volume is on x-axis, and then ICP is on the y-axis. Okay, in terms of millimeter of mercury. Cool. So starting with the 0, 20, 40, 60, 80, 100 millimeter of mercury. Okay, now answer stop. Yeah, so now I'm just showing you 10 millimeter of mercury. I told you, this is the level of 10. Okay, so in case of, suppose the mass, expanding mass we were discussing earlier, right? So any kind of expanding mass within the skull, within the skull, it will maintain initially a normal intracranial pressure, normal ICP initially. Okay, but I'm talking about these levels. Okay, 10 millimeter of mercury, as I told you. I'll write it here. Under normal conditions. Sorry, I forgot that time to write normal conditions. So what is the ICP value? I said 0 to 10 millimeter of mercury if you measure relative to foramen of Monro. Okay, so now okay, factors affecting ICP, that will come later, don't worry about it. It can go, acha, what is the maximum value? It can go up to 1000 of Hg. Depends upon like what kind of activity it is. If it is a straining, or maybe the even the coughing, if it is a like it may occur transiently, no doubt, yes, it can go high. Okay, fine, let us come back to this picture. So either this level, like initially it can maintain the normal ICP even though there is an expanding mass inside the skull. Okay, now Later, what happened? Further, volume also increasing. See, volume is increasing. Okay, so further increase in volume will produce more ICP, because it is not just the pressure. What happened later? The volume is also increasing. Okay, so expanding mass is having the volume as well, right? So further increase in any kind of volume here on, it will increase the ICP value. Cool. So this is how it will happen in the later stages. Okay, so this is how you should understand the how it works. However, intracranial pressure is again monitored with a ventricular catheter. When we study about the investigation, we'll learn more about it. Ventricular catheter, it is used to measure the ICP. Okay, well, now you understood that point. Intracranial mass expands and compensatory reserve diminishes. So that's how the it is pressure elevations are more obvious. It become more and more uh, suppose it become more and more as the pressure increases. Okay, but initially it may not show more pressure. So more pressure eventually, and then fall in cerebral perfusion pressure. When it reaches to any, suppose any critical level, then reduction in the flow also may occur. Okay, okay, don't worry. I'll make you to understand the interrelationships. Intracranial pressure increases. I will come on that. Don't worry about it. Which all factor is there and how it is there. I will summarize whole our discussion into this. Then we will go for the clinical part. Don't worry about it. Which all can cause it? Let us come on that. Cerebral edema. Cool. Okay. Or CSF flow obstruction. We were discussing, right? CSF or outflow obstruction, basically outflow. Okay. Now then, expanding intracranial mass also. I'll write expanding mass. I hope you understand that is intracranial one I'm talking about, right? So basically, what extra expanding mass is doing? It is causing brain shift, right? Brain shift. I mean to say midline shift. You would have seen in the report midline shift. They write brain shift. Okay, so brain shift, what it causes in turn, says CSF outflow obstruction. Okay, okay, let me see, let me write it here, outflow, rather you could understand better. So this will cause outflow obstruction, and again intracranial pressure rises. Okay, so brain shift can cause what, basically? Yeah, this is summarizing all our discussions here, like causes and interrelationship, basically. Brain Damage, vessel damage, everything we were talking about, right? So brain damage causing what? It is actually affecting even the blood brain barrier, damaging, damage blood brain, we were talking about earlier, right? Same thing, blood brain barrier. So suppose blood brain barrier is damaged, it will cause what? Cerebral edema. Well, it can brain damage, that means what? It will impair your mechanism of auto regulation, very important to understand. Okay, impaired auto regulation, that can cause what? You tell me, in terms of flow it will reduce or increase? It will reduce. And it will cause what? It can cause flow is reduced, that means there is a hypoxic brain injury chances. So we'll write it here, brain tissue hypoxia. Cool. Brain tissue hypoxia, that can also result in ischemic changes, that could be the brain damage, right? Well, now other region of intracranial pressure down is any which way when the cerebral blood volume is higher. Clear? That's what we were talking about. So when can volume be higher in terms of pressure? When the CVP, central venous pressure, decreases. Then cerebral pressure decreases, that means volume is increasing, right? It's normal. It will cause what? Intracranial pressure higher. Both pressure are different. This is intracranial pressure. This is, I'm talking about central venous pressure. Yes. And anything else can cause more volume, cerebral blood volume, cerebral vasodilatation. It can cause what? More cerebral volume. Anyway, I would say that intracranial pressure causes less cerebral perfusion pressure, right? This we have studied. Less cerebral perfusion pressure, then only the pressure, intracranial pressure will be more, that means the less cerebral perfusion pressure. Cerebral perfusion pressure is nothing, it's like a systemic BP minus intracranial pressure, right? So if more intracranial pressure is there, that means cerebral perfusion pressure will be less. Very simple, simple mathematics. So what happened here? So cerebral perfusion pressure is less, that means it will anyway cause, if we talk about in terms of cerebral blood flow, cerebral blood volume, it will cause less pressure means more cerebral blood volume. See the interrelationships, very simple. Diagram looks difficult, but if you see, the process is very easy. This one diagram may make you to understand and the concept too well. Okay, so now, and what all can cause less cerebral perfusion pressure? Normal systemic BP. If it is reduces, that is hypotension, that will also cause low CPP. Arey Baba, CPP is what? You remember the formula? CPP, cerebral perfusion pressure, is systemic BP minus intracranial pressure. So it's very simple that if systemic BP is itself is low, it will cause the CPP low, because this is the more. This would be more than the ICP. Now, what I'm saying you, if ICP is more, that means suppose systemic BP is 160. It has come 160, and ICP is now increased. ICP is 40. So 160 minus 40 is 120. Normal ICP was 10. 160 minus 10 is 150, which is less. Now understood the concept? So I was telling you, less systemic BP will cause the less CPP. Less CPP will cause in turn the less intracranial pressure. Okay, all are interrelated. So this image I have made it to make you understand, yes, see how interregulation work. Okay, severe reduction in CPP. Severe reduction, if CPP is severely reduced, what it can be? It will cause low cerebral blood flow. Flow will be low. Is this okay? Low CPP, that means cerebral perfusion pressure. It will be anyway causing impaired autoregulation. That you understand. So this will anyway cause less flow. Okay. Okay. Apart from this, what all causes our cerebral vasodilation? We learned about, I'm talking about chemical regulation, we learned about chemical regulation, right? So cerebral vasodilation, what all the causes are? No, tell me about this I have shown. Sorry, one mistake it is. Cerebral perfusion pressure will cause, sorry, I was really sorry, I was little confused while making the arrows. Yeah, so it will cause what? Low cerebral perfusion pressure will cause cerebral vasodilatation. Okay, so and tell me about the chemical reason. What all the chemical reasons are? You know that cerebral vasodilatation. PuCO2 high. Anything else you know? PO2. Just 1 minute. Just 1 minute. Able to see everyone? Yeah. So yeah, tell me what PO2? PO2 will be low. Especially, I gave you the condition. It should be too low to go below the 50 of mercury. You remember I was telling you. Usually, lack of PO2, like it doesn't cause the cerebral vasodilatation so early. Okay, this can cause PCO2 can cause severely reduced PO2 can cause anything else pH wise. Ah, extracellular pH should be low. That means the acidic environment. Okay, so metabolic byproducts basically. This also can cause the cerebral vasodilatation. Now, if there is lot of oxygen is low oxygen can cause hypoxia, right? So all these are interrelated. See this, now you see this diagram, this flow chart, and find yourself in a better position to understand the whole process. Whole our discussion I have summarized in this flow. Okay, so practice this. Very simple. Keep intracranial pressure in your focus and then start interrelating everything. More intracranial pressure caused by cerebral blood flow, more cerebral blood flow. It can be caused by lack of central venous pressure. Okay, more cerebral blood volume can be caused by cerebral vasodilatation. Chemically, if we see chemoregulation, low pH, low extracellular pH very low PO2 and very low PCO2. Very low PO2 can cause brain hypoxic injury. Brain hypoxic injury can cause brain damage. Brain damage can have a impaired autoregulation. That in turn can cause CBF, cerebral blood flow low. Low cerebral blood flow can cause further brain tissue hypoxia. Okay, brain damage can be caused even by the brain shifting because of expanding mass. Expanding mass has more effect on intracranial pressure because mass is increasing, so pressure will increase. Skull is a tight structure. Okay, and expanding mass has a cascading effect on the brain shifting also. More like a brain shifting will cause the CSF outflow obstruction. CSF outflow obstruction has in turn effect of effect over the ICP, intracranial pressure will increase. Okay, and then we were talking about brain damage, damaged blood brain barrier that can cause again the cerebral edema. More cerebral edema means more pressure. Very clear? Okay, more pressure, intracranial pressure, that means cerebral perfusion pressure is low. Anyway, systemic BP, if somebody has a hypotension, cerebral perfusion pressure can go low. Hmm? So low cerebral perfusion pressure, that means severe reduction of CPP. Suppose severe reduction of CPP is there, then in that case also cerebral blood flow can reduce severely. Clear? So you see this chart, if you master, you know, it will be very good for you. Rather writing ICP, I'll write interrelationships. Okay. Now let us move on the next picture of the clinical side. Cool. Everyone is understanding? Any difficulty? Clinical effects of more ICP. So more ICP definitely will give some signs and symptoms, but normally uh, more I like like I'll tell that raised ICP will give signs and symptoms, but normally if blood flow is maintained, does not cause any neuronal damage. Normally if it is not, but cerebral blood uh, just a minute, cerebral blood flow should be maintained. If blood flow is maintained, there is no problem. Okay, then neuronal damage will not be there. So now clinical features. Okay, headache, definitely headache is there, one feature. Usually this kind of headache is worse in morning. Okay, and usually bending aggravates it. Stooping, bending aggravates it. Second is vomiting, especially in the acute ICP raging, vomiting has been seen. And last is papilledema. So it's basically, it's related to the CSF flow, CSF obstruction. So papilledema means like more CSF pressure in optic nerve. Okay. So what does it do? Impedes venous drainage. Okay. So if it is impeding the venous drainage, that means basically in the optic neurons. So what will happen? It will cause the swelling of optic disc. Okay, optic disc swelling, and obviously later what will happen, like retinal hemorrhage. Okay, retinal hemorrhage, disc hemorrhage. That's how the like vision could be at risk. Okay, vision at risk. Then normally brain shift doesn't cause it. Okay, doesn't it's not necessary, sorry, it doesn't necessarily occur with the brain shift. Okay, so brain shifting is a different thing. In brain shifting we have to understand certain points. Okay, we'll see one by one the even the brain shifting part today itself. Okay, if you understand brain shifting, it's very easy to understand the conditions related to it. So first of all, brain shift types we will see. What kind of brain shift could be? So first is central. Central. Then there is something called lateral. Then midline. Then tonsillar. Okay. Central is also called tentorial herniation. Okay, tentorial herniation. Where it happens? It's a midline lesion or diffuse swelling of the cerebral hemispheres, result in vertical displacement of midbrain and diencephalon through the tentorial hiatus. Okay, so basically in the midbrain, displacement of midbrain, swelling of cerebral hemispheres, which results in the vertical displacement of midbrain and diencephalon. Okay, so this is the central, also called as tentorial. Okay, you wanted me to. Fine, I'll make you understand in image. Don't worry. Lateral. Lateral is what? It is a unilateral. Okay, one side expanding intracranial mass. Okay, also called tentorial herniation. No doubt, tentorial herniation of lateral side. Okay, in this case, what happened? Unilateral expanding mass. Okay, which caused tentorial herniation and as the medial edge of temporal lobe. Okay, that herniates through the tentorial hiatus. In first case it was which hiatus? Tentorial hiatus. Same way here it is tentorial hiatus. Through the tentorial hiatus it is a one side, basically unilateral. Obviously both can be together. If more intracranial pressure will continue, then definitely central also will follow. What is wrong in that? It will definitely happen. I'm just giving you a picture of like different this one. Okay, fine. Midline shift. It is also called subfalcine midline shift. So what happened in this? It occurs early with the unilateral, okay, one side, and it will not have a clinical effect also earlier. But same site cerebral artery occlusion that can cause the midline shift. Okay, middle of the brain will get shift. I'll make you understand picture. Don't worry about it. Okay, tonsillar herniation. It is what happened here in this case. Subtentorial expanding mass causes herniation of cerebellar tonsils through the foramen magnum. Foramen magnum is part of brain, right? You understand? Yes. Understood point? Tonsillar herniation. So suppose I'm making one schematic diagram here again, just to make you understand. This is where it goes for spinal cord. Okay. This is the cerebellar zone. Okay. So let us come on the picture. This is the midline of the brain. If this gets shift any of the side, this is midline shift number 3 I'm writing. You can relate it to this. Okay, you can relate to this. Suppose there is a intracranial mass this here. Okay, intracranial mass is here. And there is a shifting of herniation of, basically I would say that herniation of cerebellar tonsil through the foramen magnum going down. This is the tonsillar herniation. I'm writing it number 4. You can understand that. Okay. Suppose there is a flow here. I'll put it in black. Don't worry about it. It was an intracranial lesion. It was going down. Okay. Now, okay. Now, suppose in the midline of the brain, near the midbrain, it causes the shift. Okay, any midline lesion or diffuse swelling of cerebellar hemisphere. Suppose cerebellar hemisphere is getting diffuse swelling, so it will be causing what? It will be causing the vertical displacement of midlines, midbrain and diencephalon through the tentorial hiatus. So this is called the central, sorry, central herniation, central type of tentorial herniation. This was the number 1. Oh, just 1 minute. This was the number 1. Okay. Where is number 2? Where could be the number 2? Unilateral. Suppose there is a mass, intracranial mass, which is expanding in one part of the brain. Okay. Which is causing pressure all through its surroundings, like all to the surroundings, which it will cause. It will be causing the tentorial herniation of lateral type. So unilateral expanding mass causing tentorial herniation. Why? Because medial edge of temporal lobe herniates through the tentorial hiatus. ठीक है? Tentorial hiatus. So this will be called number 2. Number 2 what? Tentorial herniation of lateral type. Clear? Very nice. Yes. So what could be the clinical effects of the herniation? Yes, but what could be the clinical effects? Multiple, right? Multiple, right? So So cardiovascular changes, okay, maybe increase in the blood pressure or fall of like a pulse rate, you know uh, if it is associated with expanding intracranial mass and probably resulting from the you can say medullary compression. So clinical value of these observation is, usually it is overemphasized. They are normally not present, but whenever they are present, they will be preceded by a I can say kind of coma kind of situation. Okay, so clinical effect of brain shift is very very important. We need to understand where exactly the brain shift is happening. Okay, suppose it is happening in the like tonsillar herniation and it's happening in the like what I was saying you the like the through the it causes it actually comes out through the foramen magnum. So in that case, what will happen? It could again the it can go for upward also. It can go for the where which is coming down here, what I was saying you here, tonsillar herniation which is coming down, it can go again the up also. Its projection can go up also. So projection up will harm what? It will harm cerebellum only, right? So it will cause what? It will cause the neck stiffness because it is in the lower brain, right? Neck stiffness and head tilt. So brain stem pressure will usually result into what? Brain stem है, ध्यान से बोलना क्या होगा? Conscious level will go down. Coma kind of situation can come. And any other things? Brain stem है, ध्यान से बोलो. Yes. Respiratory issues. It can cause the respiratory arrest also. Just one example I'm telling you. Clinical effects of brain shift. Can cause or not? Okay, you want to understand even better. Well, just 1 minute. Okay, clinical effects of brain shift. What I was saying you that suppose there is a tonsillar herniation. Okay, tonsillar herniation, है ना? So we'll see. Yeah. So like this, it is. Suppose this is the bone, and this is how the spinal cord has gone up, and this is how the foramen magnum. So this is the cerebellar area to make you understand. Okay, suppose there is an intracranial mass is increasing inside. Okay, intracranial mass is increasing inside. What can you expect? You can expect it will be pressurizing all the areas, right? So and through this it will go down, right? This is how the tonsillar herniation. So tonsillar impaction, in foramen magnum. Okay, through foramen magnum only, no? Magnum only, no? So what it can cause? It can cause the neck stiffness, or it can cause the head tilt. Cool. Now it is causing the pressure over the brain stem as well. It is causing pressure over the brain stem as well. And it can cause even the pressure on the upper cerebellar, like upward cerebellar herniation, we say that cerebellar herniation. It can cause even the pressure on that, and it's usually present. It's not like that it is not. Suppose the brain stem get pressurized. Okay, brain stem get pressurized, so what will happen? Respiratory distress. So this is how it works. Okay, so this is your homework that you bring it. Oh my god, this is your homework that you bring it, the clinical effects of brain shifting for other types also. Okay, I'm writing here other types homework. करके लाइए अगली बार, ठीक है। नाउ, so how do we do for the like intracranial? So you understand like what is the investigation, and what is the investigation? You have to go for the CT, MRI, right? Okay. Treatment part we'll see next time. Okay. Treatment part we'll see next time, when we will come into the treatment part. Okay. It controls mannitol infusion. It controls CSF withdrawal. It can control sedatives. Okay. It is controlled by sedatives. It is controlled by hyperventilation, decompressive craniectomy, and hypothermia, and steroids, obviously. Cool. Yes. True. Definitely. Definitely. Yeah. Like the treatment part, right? Treatment part only we were talking about. Okay, cool. So treatment part, methods of reducing the intracranial pressure you need to go for. Okay, so methods to reduce ICP, methods to reduce ICP. Okay, so just go with the point wise. Mannitol infusion. Second is CSF withdrawal. Sedatives. Then controlled hyperventilation, because there is a definitely a problem of partial pressure of carbon dioxide. So controlled hyperventilation is very, very important. So bringing PCO2 down to say like the level is 3.5 kilopascal by hyperventilated or sedation activities, especially for the paralyzed patients where it can cause the vasoconstriction. Okay, so apart from that, decompressive, you remember these all methods, please. Decompressive, craniectomy, hypothermia. Hypothermia is a condition, but hypothermia is a method of reducing ICP as well. Yes. Yeah, cooling to particular temperature like 33 or 34 degrees C, it will lower the intracranial pressure. No, usually in the like head injury cases and all, it is failed. So it is one technique what I study. So I'm teaching you. Steroids, obviously. So these all are the methods to reduce the ICP. याद रहेगा? Yes. Sedatives, obviously propofol, barbiturates, all these you can just remember the name. Okay, so with this, why did I write it in caps? Okay, so with this now we are done with the raised ICP.